5, 4, 3, 2, 1. Yes, good evening, dear colleagues. Thanks for the host for inviting me and for the kind introduction. It's interesting actually to attend these multidisciplinary meetings where you get to hear the view of different specialties on one disease or more than two interrelated diseases. It was interesting to listen to the view of the cardiologist on inflammation and autoimmune disease, and to listen to the view of a rheumatologist on atherosclerotic disease in autoimmune conditions. And now this will be the last talk in the meeting. As a cardiologist and an interventional cardiologist, I'll be talking about how we view LDL management and atherosclerotic disease. So in the coming 20 minutes, I'll be talking about atherosclerosis. What do we mean by a risk factor and what do we mean by a cause? What's the value of LDL lowering in cardiovascular protection? What tools do we have for LDL lowering? And how do we use them? Who benefits most? And finally, I'll be talking about some of the concerns that I see in treating physicians when we encounter very low levels of LDL cholesterol after treatment. So first, trying to understand what's atherosclerosis. We know that atherosclerosis is the major killer in our times. And we know that there are several factors contributing to the development of atherosclerosis. We have obesity, hypertension, diabetes, genetic factors, thrombotic states, inflammation, as previously mentioned eloquently by the colleagues. But these all count as risk factors. And what does a risk factor mean? This is a trait or a condition that increases the chances of developing a disease. But it's not essential for the disease to happen. So we might have the disease, which is here atherosclerosis, without having risk factors, without having diabetes and hypertension. And we can have the risk factors without essentially leading to a disease. These are the risk factors. But we should differentiate these from a cause. And the only solid cause that we know for atherosclerosis is dyslipidemia. And this is not my own personal view. This is the view of the European Society of Cardiology back in 2017, where they issued a document statement that describes why they view LDL as a cause of atherosclerotic disease, and they provided evidence from genetic, epidemiologic, and clinical trials. This was a consensus document, and the same document was reiterated in 2020, but it was forgotten in the times of COVID, again stressing why LDL is a cause of atherosclerotic disease, looking at pathophysiologic, genetic, and therapeutic insights. And this is just part of the evidence that the European Society of Cardiology quotes, proving that LDL is a cause, not just a risk factor for atherosclerosis. I'll be focusing on two main proofs. The first is causation, the second is the effect of therapy. We've seen several trials that included millions of people worldwide, showing that the cardiovascular risk is essentially related to the LDL values in the blood in a dose-dependent manner. And that whenever we reduce the LDL cholesterol, we have trials on more than 200,000 participants, more than anything in medicine. And these show a consistent relation. Whenever we reduce LDL cholesterol, we prevent atherosclerosis. So this is how cardiologists view atherosclerosis and its sequelae. It's basically an elevation of an LDL as a part of dyslipidemia that induces an inflammatory state exacerbated by hemodynamic stress, culminating eventually in a thrombotic event which can be fatal. So the basic foundation for development of atherosclerosis is a dyslipidemia, atherogenic dyslipidemia, and there is no more atherogenic particle circulating in our blood more than the LDL cholesterol and the small component, of course. Why? Because they have the proper size and they have the proper composition. The size allows them to enter into the subendothelial space, unlike chylomicrons, and the composition, they have a good component of cholesterol esters, triglycerides. So the LDL circulates in the blood, and they have their peculiar ApoB protein, which allows them to stick into the subendothelial space, into the endothelium, And our bodies are wired to view the LDL particles as injurious foreign bodies. So our innate immune system reacts with the LDL particles as a foreign body. Macrophages in the front line, they tend to engulf the LDL, and as LDL accumulates, the macrophages keep engulfing them until the macrophages swell and they become like a bag of oil. We call them the foam cells. And these foam cells, with cholesterol crystals and other inflammatory components and fibrous tissue, they form the fatty streak, which is the starting point in the development of atherosclerosis. And as LDL levels are high, atherosclerosis builds up until we reach the stage that this atheroma ruptures and induces a fatal or non-fatal event. And the nice thing, we have solid evidence beyond any doubt that whenever we reduce the LDL cholesterol, we get benefit. And this is more of a solid arithmetic relation. If we reduce LDL by 1.5, then we have a relative risk reduction of around a third, 33 to 34%. And the further reduction we achieve, then the further reduction in risk that we get. For 2 millimoles, we get 40% relative risk reduction. And unlike other cardiovascular risk factors like hypertension, where we see a J-curve effect, here with the LDL, we didn't reach the J-curve effect yet. In the old studies where they targeted LDL cholesterol of 200, whenever they reduced LDL in secondary prevention or primary prevention, we see a reduction in cardiovascular risk. Whether we're starting by 180 or 160 or 140 or 80, or even when we reach 60 or below 60. So there's no J-curve. And surprisingly, lowering LDL seems to be beneficial for everyone. If we only exclude females in the childbearing period, we'll find that the young, the elderly, the high risk, the low risk, the vascular disease or no vascular disease, elevated LDL or no elevated LDL, they all benefit from lowering LDL in terms of cardiovascular protection. Looking at the curves here from the cholesterol treatment trialists that has tens and hundreds of thousands of patients, whether the patient is diabetic or non-diabetic, the benefit is the same. Hypertensive or not, the benefit is the same. Smoker or not, they all get a reduction in around 25 to 30%. Above the age of 75, less than 65, the benefit is more or less the same. Males and females, they derive more or less the same benefit. Looking here at the elderly population above the age of 70, you see that they tend to benefit more even than the younger population. So should we give lipid lowering therapy for everyone? If everyone benefits, should we give it for everyone? The answer, of course, practically we cannot do that for many reasons. So we tend to focus on those patients who are at higher risk for developing events, and we target them. Why? Because we know that patients with higher LDL baseline cholesterol and higher risk of cardiovascular events, they get higher reduction of events when they are given lipid lowering therapy. So we need to focus on the high risk and target them with the strongest therapies that we have. And this concept has been embraced by the ESC guidelines in 2020. So the target LDL value for someone who's of extreme risk, very high risk, like a myocardial infarction, is much less than the target that is needed for someone who's low risk or moderate risk. So for the majority of our patients that we see in the cardiology practice, we target an LDL reduction more than 50% from the baseline, regardless of the baseline value, and targeting less than 1.5 in the very high risk, less than 1.8 in the high risk. So the concept that I need you to grasp, that whenever the patient has a higher risk, then the target should be lower. So we've seen that lowering LDL is beneficial in most situations. What are the tools that we currently have to lower the LDL? We have several therapies. The oldest one are the statins and the bile acid sequestrants, but a big bulk of the evidence that we have come from statins. Then we had ezetimibe, which inhibits the absorption of cholesterol in the intestine, and then we have the injectables, the monoclonal antibodies, which are the strongest agents currently available. And I'll go through the evidence that we currently have for each of these agents. Statins have been there for almost 3 decades with lots of trials. Ezetimibe is relatively recent, only 2 decades ago, and PCSK9 inhibitors less than 10 years ago. So statins, very protective. They have a bulk of evidence, but the problem with statins that I will be showing here lies in their potency. Looking at a high-intensity statin like atorvastatin or rosuvastatin, sometimes we give a patient a 10 milligram of atorvastatin or 20 milligram of atorvastatin, and we achieve some reduction of LDL. And we think that if the patient didn't reach the target, so let's double the dose. Maybe the patient reaches the target. But I'd like you to look at the numbers here. Whenever we double the dose of statin, we just get only an extra 7% reduction in the value of the LDL. That's one of the reasons why statins alone may be not enough to reach the target LDL in a big proportion of patients. Another good reason is the side effect profile of statins. And the main limiting symptom for patients is the muscle aches and the stiffness and the cramps. And I'm talking here to rheumatologists, where this is the bread and butter. Muscle pains and aches is what you see daily. So the last thing you need to see in your patient is giving him a medication to lower cardiovascular risk, but he exacerbates a complaint that you don't want to hear. So this is a major limiting factor and results in discontinuation in a sizable proportion of patients. The other issue with statins is that they are associated with a small but statistically real increase in the risk of diabetes. This increase in the risk of diabetes is there, but it's very small, and I need you to remember that the benefit we get from statin exceeds any risk that can be induced by a small chance of developing diabetes mellitus. The other agent is ezetimibe, and the glory of this agent is that it works as an add-on with statin therapy. It has been used in a trial in patients with acute coronary syndromes, and it was shown to reduce the event rate after 6 or 7 years of use. So this is it's not a very potent agent, but it's good as an add-on. It gives us an extra 15 or 20% reduction on top of statin therapy. But what we know from real life, if we count only on statins with their limitations and ezetimibe, that the majority of patients worldwide, and in our region we're not an exception, the majority of the very high-risk patients who need the treatment to save their lives do not reach the target. In our study, 68% of patients do not reach the target, and this is a failure of the treatment or failure of the system. And so we have a very potent agent, which are the PCSK9 inhibitors. What's PCSK9? Let's go back and understand how is LDL removed from the circulation. It's removed via the LDL receptor. It's a receptor on the surface of the hepatocyte that tends to clear the circulation from the LDL. And PCSK9 tends to destroy the LDL receptor. So if we have something to inhibit the PCSK9, it means that the LDL receptor function will increase and will be able to clear more LDL from the circulation. And there are antibodies that target specifically and nothing else the PCSK9. And so the LDL receptor increases and the LDL values in the blood decrease sharply. And this is the response that we see after a single injection or 2 injections of evolocumab. In the 4-year trial, which included patients mostly with stable coronary disease, you see here, starting from a baseline of 90, within a month, we are able to reach somewhere around 30, which is roughly 60% reduction in LDL. Compare this horrible squashing LDL values with the 7% increment that we see with every doubling dose of statin, which tells you how potent these injectable monoclonal antibodies are. And within a short period of time, and as long as the patient is maintained on therapy, the reduction in LDL is maintained, unlike what we see with statins. And unlike the cumbersome side effect profile of statin, muscle pains, etc. With monoclonal antibodies, with evolocumab, the adverse events are no different from placebo. So we have evidence on evolocumab in stable patients, and we also have evidence of evolocumab in patients with acute coronary syndromes. It's the EVOPAX trial, which randomized patients with a high-risk acute coronary syndrome to statin with placebo or statin with evolocumab, and they looked after 8 weeks to the LDL values and who was able to achieve the target in these patients, keeping in mind that in these patients the target is close to 1, less than 1.5 definitely, and in patients can be even less than 1 if they have recurrent symptoms. So what did we see? In the placebo, because they were given a statin, so there was roughly 35% reduction from the baseline. But when statins were combined with evolocumab, we found a 77% reduction from the baseline. How did that reflect on achieving the target? Those who were given evolocumab were very likely to achieve the target. 95% could achieve the target, and 90% could achieve a more ambitious target of less than 1.4. So in stable disease, in unstable acute coronary syndromes, we have good evidence now for the utilization of evolocumab as PCSK9 inhibitors. And so looking at the lipid-lowering therapies again, statins give us a 29% relative risk reduction. When we add ezetimibe on top of that, we get an extra just 6% reduction, whereas the PCSK9 inhibitors alone or in addition to statins, they give us 15% relative risk reduction. So we've seen the effect of lipid-lowering therapies on clinical events, on death, MI, stroke. What do they do to the plaques that we see with our own eyes in the coronary arteries? We know that statins are able to induce stabilization of the atherosclerotic plaque or sometimes regression of atherosclerotic plaque, provided that we were able to go somewhere below 70 milligrams per deciliter, roughly less than 1.5, 1.4. So if you need your patient atherosclerotic disease to be stable or to regress, we need to bring down the LDL values below 70 milligrams. And we have tools, intravascular ultrasound that looks in the coronary. They can estimate exactly the burden of the plaque, and if we give the patient our therapies, here evolocumab in the GLAGOV trial, we should be able to know which of our patients progressed their atherosclerosis and which responded well to therapy and had regression of their atherosclerosis. And we saw the same result again from the GLAGOV trial, that in order to reduce the progression or to induce regression of atherosclerosis, again we need to go below 70 milligrams per deciliter, 1.5, to get just 1% reduction in the plaque volume. And it's hard to understand how just 1% reduction in the plaque volume reflects in 20 or 30% reduction in cardiovascular events. We theorize that it's not just the volume of the plaque, but it may be the composition of the plaque. Some plaques that have a thin surface and are full of macrophages and inflammatory cells tend to rupture more and cause more atherosclerotic events than stable plaques. This is a study that looked by optical coherence tomography, which gives us a detailed look of the atherosclerotic plaque. They randomized patients on top of statin therapy into placebo or evolocumab, and they looked at 96 weeks or 50 weeks by the picture. How did the atherosclerotic plaque change with this intense therapy, lipid targeting LDL? And they found that patients who were given evolocumab, the fibrous cap, which is the capsule protecting the plaque, became more thick, which means that the plaque is more protected from rupture. And the arc of lipid, which is the dangerous part of the plaque, becomes less, and the lipid length, the longitudinal length of the plaque, also became less. So these therapies work. They lower the LDL values, they reduce MI, death, and stroke. They tend to regress atherosclerosis if we reach the targets. So how do we utilize them, and who benefits the most? In our practice, we tend to look at the patient's presentation. So this tells us his risk category, and we understand what's his baseline value, and so we know what's the current status and where do we need to reach. And based on the difference, we choose our therapies, keeping in mind that a high-intensity statin would give us at best 50% reduction. And if we combine it with ezetimibe, that would give us 65% reduction. But unfortunately, these two agents alone, even if fully utilized, will not be sufficient for many patients. Imagine a patient who starts with an LDL value of 4, and he is very high risk, and we need to bring this 4 down to 1 or 1.5. It means we need to go approximately 75% LDL reduction. And you can see here, even if the patient tolerates the highest intensity statin with ezetimibe, we will not be able to reach that. In order to reach that, we need to combine a PCSK9 inhibitor and a statin in order to achieve a 75% reduction in LDL. So we need to focus on patients who are of very high risk, who benefit more from these combination therapies. And we know from the FOREAL trial on evolocumab that patients with 2 prior MIs, they have a bigger relative risk reduction and a smaller number needed to treat. So this is a population that you should strive to give them the therapy. The other group of patients are patients with multi-vessel disease. Again, the relative risk reduction is 30%, and you need to treat only 29 patients to prevent 1 event. Again, patients with peripheral arterial disease, you see the relative risk reduction here is around 27%. The number needed to treat again is 29 patients, is 29. So these are another cohort. This is another cohort of patients that we need to target with our intense therapies. And we expect that the coming guidelines, maybe in 2 or 3 years' time, will embrace this idea of combining therapies early on. So this is a speculation of what would the guidelines look like. And looking at very high risk patients, they would receive from the start combination of statin ezetimibe, and we see them in a month or 2. If they reduced their LDL, if they didn't reduce the LDL 50% or didn't reach 1.4, then we have to add a PCSK9 inhibitor. If they reduced more than 50 and reached the LDL less than 1.4, this is well and good. And there will be another extreme high risk patients like those with multi-vessel disease, those with peripheral arterial disease, those with more than 2 myocardial infarctions, where we may start combining statin, ezetimibe, and PCSK9 inhibitors early on the course of the disease. So if we utilize these therapies, we combine statin with PCSK9 inhibitors, we tend to see very low values of LDL. In patients, we see LDL values less than 1. And so I see some of the colleagues who are afraid that this may harm the patient in a way or another. And the truth is it's not harmful at all. Looking again at the FOREAL trial, the subgroup of patients who reached very low levels of LDL, which is less than 1 millimole. And you see what happens as the LDL goes below 1 and even below 0.5. And you see here that we still get reduction in atherosclerotic events even when we go below 1 and even when we go below 0.5. It seems that the ideal LDL that we were created to live with is probably in the range of 0.2 or 0.3. So going below 1 is definitely useful, and it protects from more events. And again, it's not harmful. There was no increase in type 2 diabetes, no increase in cancer, no increase in cataract, no increase in adverse events. So the message here, if the patient gets an LDL very low, less than 1 or less than 0.5, please don't stop the therapy and keep treating the patient, because it's beneficial and it's not harmful. So to conclude, I need you to remember that LDL is not just a risk factor, it's a cause of atherosclerosis. Lowering LDL is beneficial for almost everyone, old, young, high risk, low risk, excluding, of course, ladies in the childbearing period. We always try to bring down LDL as much as we can. We use combination therapy now early on, especially the highest risk individuals, where we strive to give them combination therapy, and even we go into arguments with the insurance that this patient should get the therapy, because we know that atherosclerosis progression can be stopped or reversed if the patients are given the treatment and their LDL values reach the target. I hope you enjoyed it, and I'll be ready for your questions. Thank you so much.